Systemic complications. So the difference between systemic complications and local complications is systemic complications occurs throughout the body within our system, and local complications occur in a small localized area. So that sort of makes sense. So the first one we'll look at is local anesthesia overdose. So this is a local anesthesia drug, whether it be lidocaine or prilocaine or articaine. And depending on the drug, most of the drugs will follow this sequence. Initially, you will observe central nervous system stimulation, and that's caused because you've injected the drug very quickly within a blood vessel. There was no aspiration, and the brain is well perfused with blood. So the drug enters the blood and it stops first, and it inhibits or it stops our inhibitory neurons within our brain. So it kind of inhibits those. So the excitatory neurons take over, and you see an initial central nervous system stimulation. But very quickly, the drug acts upon our excitatory neurons and shuts them down too. So it's usually central nervous system stimulation followed very quickly by central nervous system depression. So you may see a patient that's kind of excited, talking a lot, and if they quickly go into like a depressed state, they're lethargic, they cannot answer questions, follow commands, then you start to say, is this a local anesthesia overdose? Because that initial central nervous system stimulation sort of mimics patient anxiety. Patients can talk a lot, when they're anxious. So if you see stimulation followed very quickly by depression, think local anesthesia overdose. The other thing, the key factor here, circumoral tingling and numbness. It's bilateral. You may have anesthetized, let's say you gave an IA, lower left IA. In the patient, you sit them up, the injection's gone well, you didn't aspirate, you just deposited that solution in 10 seconds. You sit the patient up, and they may say all around their mouth feels numb. Now that's not normal if they're saying all around their mouth and their lips are all numb. We're only looking for a quarter of the lips. So if they start talking about all around their mouth, again, think LA overdose. Now we know from pharmacology that lidocaine does not follow this sequence. The patient will not go through stimulation. They go directly to central nervous system depression. Now vasopressor, or essentially epinephrine overdose, now that usually is caused from epinephrine impregnated cord. And cord is something that a dentist uses to pack around a crown prep. They actually will pack this cord, and sometimes cord is impregnated. There's epinephrine in it to minimize the bleeding. So they pack the cord all around the tooth to sort of push the gums, gingiva, away from the tooth prep. So when they get an impression, the crown, when it's seated, will go subgingivally. So they don't like it to be bleeding a lot because that could interfere with their impression. So epinephrine overdose also looks a lot like patient anxiety. The difference is they may experience a severe throbbing headache. It's like, my head is killing me. This epinephrine overdose is probably much more rare. And even local anesthesia overdose, I'm not even sure if it's been documented in dentistry at all. So these complications, and we'll be very safe with slow deposition rates and lots of multiple aspirations so we're not in a blood vessel, are very unlikely to occur. Now another systemic complication, which can also, this one, an allergy could also occur locally, but let's look at the systemic effects if you deliver something to a patient that has an allergy to it. Now, usually a person, if they're having an allergy to an injected local anesthesia, cartridge. They're allergic to the preservative that preserves the vasoconstrictor, and that's sodium bisulfite. That's what they're allergic to. So if you have a patient, especially a patient that's a steroid-dependent asthmatic, for some reason, steroid-dependent asthmatics are much more susceptible to being allergic, having a systemic allergic reaction to sodium bisulfite. So what do? Patient comes in, steroid-dependent asthmatic. They also tell you, I have all these allergies. We'll use a plain solution. We'll use a 3% mepivacaine plain for someone that reports an allergy. Another drug, like if a patient tells you, I was allergic, I had an allergic reaction to Novocaine, they'll usually say like 30 years ago, they were probably allergic to an ester, which you can't actually deliver in the United States anymore within a cartridge. Procaine, also known as Novocaine, is not available in the US. And the patients used to be allergic to PABA, that para-aminobenzoic acid, that's a byproduct of the ester breakdown. So those aren't available anymore. So what does a systemic allergic reaction look like? The patient may have hives, right? They may have like a runny nose, things like that. If they have hives, a runny nose, you know what we're thinking for that? Diphenhydramine, Benadryl, this is an allergy. We want to watch for things like airway involvement. If you've delivered a drug, they're allergic, they start talking, here are the key words. My lips, my tongue is swelling. I'm having difficulty breathing. Okay, ding, 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 ding. Anaphylaxis, right? And what do we need for anaphylaxis? Epinephrine, which we're not allowed to deliver. That is the drug of choice, but as hygienists, we are not allowed to deliver epinephrine. But I want you to know, anaphylaxis, epinephrine, hives, no airway involvement, we're thinking Benadryl. So those are our systemic complications. Now, local complications, we could have a localized allergic reaction. This will be especially aligned with a topical placement of benzocaine. So if you've used benzocaine as the 20% benzocaine on the cotton-tipped applicator and the patient has like a delayed reaction, maybe a day or two, they have like a bubble, or it almost looks like a hive, like a fluid-filled sac, right where you've placed the topical anesthetic, they may have a localized allergic reaction. Another local complication that we can see is needle breakage. How do we prevent needle breakage? Well, we are going to select the appropriate gauge and the appropriate length for the injection that we're given. So we need to know how deep are we going. When we're doing an IA, we want a long needle. We want that 25 gauge. So it helps to prevent needle breaking or needle breakage if a patient moves. Don't insert it to the hub. That's the weakest part of the needle. So imagine you take a 30 gauge short, super flexible needle. It's really short. You've hubbed it and the patient jumps. That is the equation for disaster. So use the appropriate gauge for the injection, the appropriate length of the needle. Don't insert it to the hub. Also, have an open pair of hemostats on the ready. If it breaks, you can grab those hemostats and try to retrieve the needle as it sticks out of the tissue. Because that's the other problem with hubbing the needle. If you hub the needle and the needle breaks at the hub point, the tissue kind of goes and sucks the needle in. If you're not to the hub and the needle breaks, a piece of it's still sticking out, and that's the piece you can grab and pull out. Facial nerve paralysis, cranial nerve number 7. It's temporary. The patient does not have Bell's palsy. Don't tell the patient they have Bell's palsy. It's transient. It will go away as soon as the body has metabolized the drug that's been delivered that is basically blocking the cranial nerve. Number 7, from doing its job. How do we prevent this? We do the bone tap for the IA. So the IO, we saw maybe a little tiny droop. The IA has that significant droop. IA is the one that is heavily aligned with facial nerve paralysis. If you don't tap the bone, you've gone too deep, you're into the parotid gland where the facial nerve passes through, and you've basically anesthetized the facial nerve versus the inferior alveolar nerve. If the patient is very droopy, we want to protect the eye. It's lost its protective reflex. It can't blink. That's why we close the eye for the patient. You can ask the patient to take out their contact and place gauze and tape and tell the patient that it will go away. Paresthesia. Now we had facial nerve paralysis, and now we have paresthesia. Paresthesia, it's very difficult to predict who will get it, and we don't even know exactly what causes it. It's basically prolonged numbness, tingling. You may have a different taste sensation for a while. It was in the past associated with 4% articaine. They'll say don't give a block with a 4% solution. You're better off giving a block with a 2% lidocaine with 1 to 100,000. Don't store cartridges in alcohol. That's also an older style of practice. They used to store cartridges in an alcohol tub to make it cleaner, but the alcohol can seep into the cartridge and maybe prove to be a little neurotoxic. So the patient calls you back. You've given an IA, lingual, long buccal. The patient calls the office back in a couple of days. Hey, I'm still numb. I'm still feeling, or I'm getting this weird, like it still feels like my tongue is asleep. You need to talk to that patient. We need to say, hey, okay, come back in. I'm going to make a documentation of where you're still feeling this numbness or this sensation. Then I'll have you come back in a couple of weeks, and hopefully it will be getting smaller. It's something that usually over time gets better. Not always, but most of the time it does get better. But just make sure, for even the patient's peace of mind, talk to the patient, let them know you're thinking about them, and you're trying to do something to address the situation that they're in. Hematoma, it's a bruise. Not always avoidable, but it can be avoidable. If you have to follow insertion depths closely. If we're supposed to go 5 to 6 millimeters, insert the needle that far for a mental, and you're going 20. If we're supposed to insert 10 to 16, 14 to 16 for the PSA, and you're going 30 millimeters, that's too deep. The patient may get, especially with a PSA, if you've gone very, very deep, you might be at that pterygoid venous plexus. If you've reached the pterygoid venous plexus with your needle, they can get a significant hematoma from that. So no, even though they're not always avoidable, if you're getting consistent hematomas with a PSA injection, you need to think about how deep am I going? Am I using a short needle? How long is my short needle? We don't want to use the needle as a probe. And I'm going to deliver all these injections slowly with lots of aspirations. So how do you manage it if the patient has a hematoma? We want to use immediate pressure, just like anywhere else, right? You're bleeding, even from a pimple on your face. The first thing you want to do, you put pressure on it with a tissue. I want this to stop bleeding, right? We want to put pressure and ice. That's the ideal thing to do, or pressure with an ice pack. That would be ideal. For an injection like the PSA, it's really difficult to put any kind of pressure in an area that's actually bleeding. Sort of beyond our fingertips at that point. So we do the best we can with pressure and ice. Trismus. Trismus means they can't open their mouth very wide, right? They're really, really stiff. It's usually due to having multiple penetrations. You've missed an IA injection multiple times and you've gone in, penetrated the tissue a lot of times, trying to get the patient numb. The medial pterygoid is the muscle that usually has trismus. The patient calls back, oh, I'm having so much difficulty opening my mouth. This is where we want to say heat and exercise, not, oh, don't try to open wide. Keep opening, open, open, open. Keep the muscle moving. And you want to use warm, moist heat. So these are some local complications that I've all put on the same page or same slide. You know, pain on injection. Patient reports pain on injection. What might it be caused from? Well, sometimes it's caused because, you know, some injections are not 100% pain-free. Sometimes it's because you're depositing solution way too fast. Sometimes it's because you've had multiple penetrations with the same needle. You've gone in 4, 5, 6 times with the same needle. The needle is dull, or perhaps it's barbed. Or another thing, you can be aspirating, and you're aspirating so forcefully you're creating like a huge stream of bubbles within the cartridge. Burning on injection. Burning on injection cannot always be stopped because the pH of solutions that contain a vasoconstrictor are lower. It's usually about a pH of 3.5 compared to 5.5 pH of plain solutions. That lowered pH can make it so the patient feels some burning. It's not, there's nothing wrong. They may just say, oh, that burned a little bit. And it's because of the lowered acidic pH of the vasoconstrictor and local anesthesia solution. Self-mutilation. I've been seeing some really great things during local anesthesia lab with everybody, you know, sort of talking to their patients, talking during the injection. We also want to make sure after injections, we talk to the patients a little bit about, you know, what they should eat, what to be careful of, so that they don't do self-mutilation, which is basically chewing on the inside of their lip. Children are really vulnerable to this. Infection. Infection should not happen. You shouldn't get an infection after you've had a local anesthesia injection unless we're using clean, sterile needles. Unless a person is severely immunocompromised and there was something with after the needle penetrated, it picked up bacteria in the patient's own mouth. Infection in current infection control, standard precaution care should not happen.